I think we'll go ahead and get started. I know people will be coming and going, and that's completely fine, and we're pleased to have you here with us. We'll start with introductions. Again, I'm Sheldon Fisher, and I work in strategy at Providence. I've been at Providence. I'm a relatively newcomer. I've been here for a couple of years, and in fact, relatively new to healthcare from an administrative perspective. And so it's one of the great benefits of my job that I get to work with people like Dr. Lada and Rhonda Prowell-Kitter, and you'll see why as we go through our presentation. But if I can ask Dr. Lada and Ms. Prowell-Kitter to introduce themselves.
Sure. My name is Robert Lada. I'm a neurologist here in Alaska. I've been here for going on 14 years now, and my background is, in addition to general neurology, is vascular neurology, which is an area of, it's a subspecialty area of neurology that's involved mainly in stroke and the whole continuum of care for stroke management, as well as sleep medicine. I'm a part of Peak Neurology and Sleep Medicine, as well as the Alaska Inpatient Neurology Services.
My name is Rhonda Prowell-Kitter. I am the Chief Financial Officer and the Plan Administrator here at the Public Education Health Trust. The trust was established 25 years ago, and I joined the trust 23 years ago. So I'm really looking forward to our conversation today about how we're going to change the healthcare delivery model here in our state.
Great. Rhonda, why don't you just tell people 30 seconds, well, maybe you'll get that into the presentation. Not everyone may know what the Public Education Health Trust does, but all right, I'm just going to jump in. And an important part of what we wanted to talk to you about is work that we're doing to create a clinically integrated network here in Alaska. And many of you may be familiar with that, but some of you may not. And a clinically integrated network is a mechanism that allows physicians to come together and to collaborate in a way that under normal antitrust rules would be problematic and might even be antitrust violations. But starting in the 90s, the FTC, that is responsible for antitrust definition, recognized that collaboration and working on quality actually has so many benefits that they understood and recognized that the benefit of allowing physicians and hospital groups to come together to collaborate on quality outweighed any potential harm to competition. And so you can see there at the bottom that there's this three-part test, which is that the integration program has to really be focused on quality. It has to be real. It has to be designed to achieve improvements in quality and efficiency. And the joint contracting has to be reasonably necessary to achieve the efficiencies, and so that the contracting, particularly initially in the fee-for-service arena, is designed and part of the broader integration. If you go out on the web, you will find lots of definitions. I like this one, that a clinically integrated network is generally thought of as a network of interdependent and cooperative providers who continuously evaluate and modify clinical practices in accordance with agreed upon protocols to control cost and improve quality. And so one of the things you will hear from us at Providence a lot is a discussion around the quadruple aim, which includes quality at the top, cost, and the patient experience, as well as the provider experience in providing a rewarding and efficient system for providers to operate in. A few of the goals, and as you think about kind of traditional healthcare models and where we see ourselves going, Alaska historically has been in the traditional category where care is siloed and patients are often left to themselves to navigate care without a lot of direction or oversight or management or support from healthcare professionals. And as we move towards a value-based care model, there's an emphasis on being able to provide support and helping patients understand how to navigate that care, and then a focus on preventive care in a data rich environment where we are really examining data and thinking about how can we control costs, as opposed to waiting for an event to present itself and then dealing with the event, which is the way it largely works today. And so what we see in other parts of the country and what we're working towards here is a model that is much more integrated and effective in terms of both quality and affordability. This is my last slide, and then I'll turn it over to Dr. Lada. But one of the things that we recognize is really critical, because it won't work if this is not a win-win for all of the stakeholders. If one group wins at the expense of a different stakeholder in the healthcare arena, well, that stakeholder that's losing is going to disengage. And so we recognize that there's got to be value to everybody who participates. And so one of the things I think you'll hear, and we can come back to at the end if there's questions, but I think you'll hear from Dr. Lada that from a clinical perspective and from a patient perspective, there are many benefits, both in terms of quality, in terms of the ease of use, and I think you'll hear from Ms. Prowell-Kitter, her goal and aspirations around how this can improve quality and affordability and ease of use for the patients. So with that, I will pass the baton to Dr. Lada, and then we can come back if there's questions on anything that I've talked about.
All right, thanks, Sheldon. I am not a economist or a healthcare individual really knows all those nuances as far as how finances are really moved through healthcare and all those type of things. But I really come as a perspective of a provider. My goal through my whole practice has always been to try to improve the care of my patients. And I do have to say, in coming to Alaska, it has been very challenging. I've been here for about 14 years. And coming from Ohio, where we have just a massive infrastructure for healthcare, coming from Cleveland Clinic environment and from just the Northeast Ohio area, one is the number of neurologists that we have available that work together as a team is dramatically higher than it is here. We are woefully underserved as far as neurologists go. So, the perspective that I'm coming from is really from the neuroscience side of it. But I think it does resonate with some of the other specialties and primary care docs in how healthcare has been historically delivered here in Alaska. When I first came up to Alaska, probably within a few years, you get associated with a lot of folks, and we get close to a lot of families. And one family in particular had a very severe injury while just on a trail, and had a severe fall with a tremendous head injury. And the initial care from the pre-hospital triage to getting him to the hospital and the initial ICU stay to stability was very well done. And the providers that are available for doing that is tremendous. And so I think, and as we know, there's a lot of providers here in Alaska that could easily be in some of the top healthcare centers in the country. But there's a lot of variability, as we all know, with our healthcare providers here in Alaska. In any case, so they stabilized him, but the majority of the care and all his rehab had to be done in lower 48 because we just didn't have the services up here. When he returned to Alaska, that was the biggest challenge. There was a lot of services that he needed. And if it were not for his wife, who was just very persistent and determined to try to find those resources, I don't think he would have done as well as he has. So he has now returned to work to a degree at a lower level, but he is independent and in finding a lot of enjoyment out of life. But I think that really sort of underscored the challenges that we have here in Alaska is the siloing of that care that Sheldon had spoke of, which is all too prevalent here in Alaska. But unfortunately, sort of business is business, and a lot of these silos really focus on the patients, the diagnoses, and the procedures that bring in more revenue. And so that creates a tremendous amount of variability in care and treatment, which ends up costing the overall system more and does leave a lot of folks at the wayside who are not getting the care that they need. And so The other aspect of it is that the silo effect is really encouraged because that's where the revenue comes in, but there really is no revenue or encouragement for system-wide collaborative care. We just don't have that here in Alaska. And so we tend to do those things that bring in the revenue for our businesses, which still is an important component. As I said, much of my time was really spent in the stroke world and developing the stroke program here in Alaska, including telestroke. And I think some of the things that really were challenging with that is that fragmentation of care, really getting from different hospital systems to other hospital systems with our stroke patients, involving our transportation, our EMS, our life med folks, all those type of things, and trying to put that together was tremendously challenging. And we've been doing it for 14 years now, and we're still moving forward with it, and we're still behind. Though I think someone had mentioned earlier, I think it was Ella, in the sense that our healthcare system is 20 years behind, and there is a very true statement. As an example, our use of thrombolytics in this state was approved in 1995. We did not use any thrombolytics for our stroke patients until 2008. That's a huge variance. So that is, maybe not 20 years, but, very close to that. I think we're moving closer to be in line with the rest of the country in regards to stroke care, but we still have a long way to go with that. And some of those big challenges is really putting and bringing hospital systems and individuals that are, in some sense, historically competing against each other, or have not had a historical collaborative history with each other. And so as an example, like with our telestroke program, one of the first ones we did was with Juneau, who the majority of all the stroke patients were transported down to Seattle. And so though their numbers were not huge, that's a huge cost to the system. And through the telestroke program and really starting to work with them, we've sort of re-navigated that, cutting down time for those patients who need to be transported, but most of those patients staying there. And that was a tremendous collaborative effort with us, their ER physicians, and the hospital to kind of work together to improve that care, decrease costs, and keep patients at home. And so that's where some of the joys have been really coming in doing this, is getting that collaboration. Though it didn't bring in necessarily new revenue for me or for our practice or any of those things, but it was worthwhile doing because it does improve outcomes. And so that whole thing is what really piqued my interest as far as these clinically integrated networks, which I knew nothing about a year ago. I mean, I had no idea even what they were, what they existed, and lo and behold, they've been going on for years. So I'm 20 years behind that aspect of it. But the idea that we could work together collaboratively with different subspecialty and primary care docs to, take that patient who has a stroke and to put them in a better position and potentially reduce the recurrent risk of stroke and improve their ability to get care when they need it, I think was very enticing for me to then sit down and really go through that process. And so as my experience so far with the CIN has been to work with primary care docs or hospitalists, our ER docs, our neurosurgeons, to really sit down and put together a program to say, okay, what would be the best thing to do? From your perspective as a primary care doc or your perspective as a neurosurgeon, what are those critical things that need to be done in order to improve those outcomes, and then putting a plan together with that in mind. And I think that's the whole thing with these CINs. It now is a way to encourage us to work collaboratively where previously we were not encouraged to do so. And that's really that foundational aspect of these CINs, which, in the past, it has always been either you belong to a large group, and there are large groups in the state that have enough resources that they can essentially do that in-house with very specific diagnosis, whether it's an orthopedic issue or cardiac procedure, where they have enough resources that they can take that person from the very beginning and really take them through that whole continuum of care to back to health. But there's not a lot of diagnoses that really fall into that category. So either you end up becoming an employed physician someplace, or you can work through a CIN. And I think that's the other nuance that's important with CINs, that you can be a part of, or being at the table to design these programs, to say that this is what good care looks like. And I reckon that, when I came up to Alaska, one of the big surprises that I had was you go to a, medical grand rounds and there's 5 people there. And that's sort of the negative of this siloing that we have. It's a very independent spirit up here in Alaska, as we all know. People do want to do things on their own there, and there's a tremendous number of individual practices with one provider, and that doesn't exist in a lot of other places in the country. And with the increased complexity of care, working together is really going to be able to create that improvement of care, both with for the patient's outcomes. From the financial standpoint, I think it will have an impact on our healthcare, which is here tremendously expensive. But also, there's a tremendous burnout that we have as physicians, and working as a team, putting our best effort into it. And if everyone's doing that, then we can have better outcomes without that burnout component. And so I think the CIN, which I'm still in the beginning stages of really understanding, I want to remain engaged with that. But I think for me, if the patient-centered component is not the primary reason that we're doing it, then I would not continue doing that. This for me, though, financially is nice to have that, that aspect that if we're all working together and create a program that works well together, that both the patients and the providers can benefit. I think for me, and I hopefully with most physicians, is that we want our patients to do better. We want there to be less complications, and we want their outcomes to be much improved. And I think this is one way for us to begin speaking with one another as physicians and to be the leaders in that. To date, it's really been the payers and the larger facilities that say this is what we're doing, and as we as physicians have to either convince them on, almost on a day-to-day basis of why I need this study, why I need to do this. I'd rather be the one telling them this is how we're going to do it, and this is the best way to do it, and we're going to get better outcomes because we're doing it this way, and then for all of us to then get that benefit. So that's my sort of clinical perspective of that. I'm a newbie into this whole world of CINs, but I think it's exciting that we're talking about it and we're actually talking with one another, and I think that's going to make a big change for everybody. So Rhonda.
Thanks, Dr. Lada. Yeah, go ahead, Rhonda. Thank you.
Thank you. And going to this new world. It worked. Great. Thanks, everyone. As Sheldon mentioned a moment ago, who is the Public Education Health Trust, and why are we here? So we are a nonprofit health insurance company that was started back in 1996 by educators here in the state of Alaska. So we're celebrating our 25th year. There are currently 24 different school districts that are participating with Public Education Health Trust, which is about 15,000 residents here in our state. We only provide health insurance for public education employees and only here in Alaska. That being said, we know that health insurance cost is one of the top 2 costs for a school district. Because our school district receives funding from the local level, but also from the state level, we understand that the cost that we are putting forth back to those districts is having a drain on our system. And what can we do collaboratively to reduce those costs or minimally stop the inflation rate or minimize the inflation rate at where they are growing? We're very proud that our admin costs are less than 5%. When we set our premium, less than 5% is going to go back from admin. What we call admin is not a doctor, not a physician, not a hospital, ophthalmologist, pediatrician, pharmacy, that is completely on the 95% side. And we're very proud of that number. But at the same time, we know that it's not sustainable. Our annual increases are not sustainable for the school districts, for the employees, for their families, for the state. We are a huge burden on our economy. So what can we do? We keep on talking about the fact that the state of Alaska, often care is 6 times greater in our market than it is in the lower 48. What can we do to reduce those costs? Our community has wonderful providers. We don't want to see a diminishment in those providers. What can we do to help them, ultimately to help the patient? That's our ultimate focus, is that patient who needs care. How can we make that care great quality at a great cost? In 1996, when the trust was started, one of the plan designs we were offering at that time had an annual cost of $5,916. That same plan design has a cost of nearly $30,000. That's a 495% increase in 25 years. My salary hasn't increased 500%. Our state's budget and oil revenue hasn't increased by 500%. What can we do? As a comparison, the U.S. Bureau of Labor Statistics said if medical care cost $5,900 back in 1996, today for the lower 48, it would have an increase of 130%. But yet in the state of Alaska, it's 495%. What is driving those numbers? What are the employers and employees doing in reaction? What we're seeing is cost shifting. We're seeing the employers take a higher deductible plan design. Maybe previously it was a $500 deductible, and now the employee is facing a $3,000 deductible. The employer is doing that so they can continue to offer benefits to those employees, but the employees are taking a larger share. They're also taking a larger share of the premium. As the premium continues to increase, the employees are taking more of that on. So any increases that were available on a salary merit increase or a step labor scale have been completely eroded by the cost of medical care for them. It is unfortunate that our education system is being taxed and burdened this way. Where my education comes from is in the sector, but we know it's statewide. It's not simply public education employees. It's all residents of our nation that are facing these increases. And what can we do to remove those silos to make it more effective for everyone? At PHT, we have been early adopters of cost-saving models. Several companies have now jumped on board, and the state of Alaska are starting to adopt those ideas as well. But it's us in that sector that are the innovators, that are the early adopters to these opportunities. We are one of the first in the state of Alaska to opt into telemedicine, medical tourism, revisiting those network agreements, as well as wellness incentives. We need those earlier adopters to have those conversations with our providers as well as our physicians in the community. Our interest in the clinically integrated network. We partnered with Providence because they recognize the need to transform healthcare delivery in our state. With Providence's quadruple aim to have better clinical outcomes at a lower cost, improved patient experience, and improved provider experience. I have sat on many panels here in the last 20 years in our state, all talking about, is it more data that we need? Is it lower admin cost? Can we do something about the 80th percentile rule? And there's been this continual finger pointing across all sectors. It's not the providers, it's not the hospitals, it's not the insurance companies, it's not the patients, but you see this continual round robin of finger pointing going on. At the end of the day, you've got burnt out providers whose admin costs are continuing to increase because they're running tests. Another group is running tests. The insurance company is denying those tests. What can we do to go into an agreement that says medical clinical outcome says this is our best practice, and for this patients of care, these are the tests that are needed, so that the provider's office doesn't have 5 to 6 ratio of admin staff supporting what their services are done. We have clinically based outcomes that says this is the best idea, and we won't have this admin appeal process with insurance any longer. The patients will no longer feel this siloed effect. So many of my members come to me and say, I've just been diagnosed. Where do I go? My spouse is in the hospital. They have this condition. Where do they go? From being in Alaska for 45 years, I have my personal referral system of providers that we've had good outcomes with. But when you have a community where the providers are talking and speaking with one another about what the best practices are, they are so more informed than I am on what steps need to occur for this next individual. Having that ability to refer an individual back to this provider and say, this individual participates in this clinically integrated network, I feel comfortable as your administrator placing you in their hands. That type of referral system is so needed in our community right now. If we're able to reduce the cost because we're not going through having 6, 7 different MRIs by different providers who want different imaging, they want to use their machines. Their machines are better than the machine across the street. If we're able to let the patient know this is our plan, this is where we're headed with your care, have them buy in early on, it is so much better than having, as we were saying earlier, this siloed effect. We do send a significant amount of our members to the lower 48, either due to cost, sometimes due to just a lack of access to care here. I'm excited by the opportunity that this system has the potential to really drive home that great experience for that patient, that great experience for the provider, so they're not burnt out. Our patients have a better quality outcome in their lives, and ultimately, our costs are reduced so that we are not continuing to have the escalation that we're seeing currently that's impacting the school districts, impacting the state of Alaska, and certainly impacting that employee. Many employees who are simply working in the custodial level, in the bus driver level, they are working for their benefits. And by the time they pay for their benefits, their paychecks are getting smaller and smaller each year. This has the opportunity to hopefully change that dynamic. We know that we are currently in a disjointed, disconnected system, and there isn't that provider communication going back and forth. My staff here at PHT are often in that role, as Dr. Lada's experience was earlier, of that spouse. We take on that role of getting medical records from this doctor's office, sending it down to this doctor's office. Will you take this patient on? What is your approach going to be to this treatment? PHT should not be doing that, right? We're an advocate for our members, but if the medical community was having those conversations between themselves and they worked collaboratively together, as opposed to if you speak to that physician, I'll fire you from my practice. It is so exciting to see this changing dynamic that will lead us in a new direction. Granted, it's new, it's exciting. We don't have proven ROI on this, but we have to change the system. And this idea that Providence is putting forth and coordinating with the community is what we've been searching for quite some time. We have, Sheldon and I have been working for about 6-9 months now on a cabbage deal, a coronary artery bypass agreement. And it took some convincing as the payer's perspective, and I think we're probably in the top 5 of payers back to Providence. It took some convincing that it may cost more, but your outcomes are going to be greater. And they have the data to show us back why this is a better direction to go. And we're expanding those opportunities. We know that the clinically integrated network is really just a legal structure that facilitates the healthcare provider collaboration, but it's those relationships that are bringing this to our table that we're so excited to be able to participate in. We're looking for that coordination between the patient, between the providers, and then us as payers, so that we can stop that finger pointing back at each other. It's not my fault, it's theirs. It's not my fault, it's theirs. The patients, especially when they're in a crisis mode, don't need to hear more red tape. They need to hear, we have a plan for your care. How can we accomplish that together? If we can align our systems to reduce waste and having those multiple tests and those multiple appeals procedures when we say no, we don't think so, if we agree to it going in, it's just going to benefit for all. Again, we are so proud of our admin cost. Only 95% goes back to a payer. So I'm misspeaking this morning. 95% goes back to the medical community. If we're able to reduce that overall 100% level so that we're not having the impact, but yet our patients get great care, our providers feel respected and wanted in our community, and as a payer, we can eliminate those conflicts, we're excited by the opportunity that CIN can bring us. Sheldon, I'll kick it back to you.
Great, thank you. I appreciate everyone. It looks like people have found the Q&A section and are putting some questions in, so we'll go to that. And I just encourage all of you that are listening to go ahead and enter your questions or upvote. We're going I think, plan on taking the questions based on kind of the order they're presented, which is based on the number of votes they get. So the first question there is from Sandra Heffern. It is, our data collection is as siloed as our service delivery. Sheldon, can you speak to how the CIN will address population-level data at both a clinical and claims perspective? And so this is a great question, and let me just share that one of the values of being part of a large organization like Providence is that we have addressed many of the questions that are issues and technology issues that need to be resolved for Alaska have been addressed somewhere in the system, and we have the opportunity to leverage them. And so a couple of examples that come to mind is, first of all, a few years ago, a number of us in the community in Ashland and elsewhere recognized that the state needed an improved health information exchange. And so Providence, we looked around our system and found a product that was being used in Southern California with literally thousands of providers on it and it being used effectively. And so we have actually brought that health information exchange to the marketplace, and it's available essentially for any of the independent practices without a cost or expense. It's something we're prepared to subsidize because we see the value of having that, sharing that clinical data. In addition to that, and Sandra will recognize that clinical data is important and critical, but claims data is also important. And one of the things that Providence has also invested in is building a data integration tool. And so we have invested, and it's taken us a number of years to get to this point, but we have a system that can ingest data literally from any of the payers in the marketplace in relatively short order. And it takes that data, it normalizes it, standardizes it, and then once it's gone through that process, it's available to be leveraged by our internally developed analytical tools, or even more importantly, when we find a third-party analytical tool that we think has merit and value, by having this normalized data set, we can interface with that third-party tool and leverage it. And so we are going through that process as a CIN right now to evaluate those tools that are necessary. And so both of those, I think, will accelerate the ability to analyze and see clinical or data both at a clinical and a claims perspective. Now, that's not to say any of you who know Sandra know that she has been an advocate for an all-payer claims database, and we at Providence also support that, and so that would be an enhancement, but it's at least in my judgment, it's not necessary for us to be able to take the first steps towards this clinically integrated network. Just going down the list, would a cost growth target implemented by the legislature help reduce the rise in overall cost in Alaska? Is the legislature considering something like that? Why or why not? Rhonda, is this something you would like to address, or I'm happy to speak to it as well, but if it's something you feel you have a perspective on, I'd welcome hearing that.
Thank you. It's certainly been under consideration. There was the Alaska Healthcare Transformation Policy that said we want to set this target for not only the growth in the annual cost of care, but also increasing the number of individuals that had access or did access a primary care physician. We often see individuals who go directly to a specialist and don't have that coordinated care that an internal medicine or a general practitioner might provide them instead. So the state, there was, I believe, a piece of the bill that included that goal. Ultimately, they're setting, the conversation is around goal setting, not specifically around it's being mandated. I think Sandra Heffern would be a great resource for that. She's certainly led the Alaska Healthcare Transformation Group, did much research for about 2 years, engaging those providers and payers, as well as the patient experience, and what can we do to decrease that overall spend. So yes, Josh, I believe there was a conversation about a goal to have to reduce our spend as well as increase our access to primary care.
Great. In order to get Dr. Lada in the mix, I'm going to jump down a little bit. Dr. Lada, there's a question here. Can you speak a bit more about the CIN structure, how the CIN structure will improve collaboration between primary care and specialists?
Yeah, I think that's it's a good question, because I think that's what makes it interesting for me. As far as specific examples, one would be for our stroke patients, for example, recognizing that those people need to follow up with either primary care with specific parameters being met, or with a neurologist within a week or 2 weeks of discharge, which is really hard to do as a neurologist, to see all these patients, but also recognizing that many of these patients may not have a primary care provider. So starting to work with primary care physicians, both to recognize like what are the goals of the neurologist as far as treatments and those type of issues, but then also be a resource for our primary care docs to say, well, what can I do better for my patients for neurology issues? Working together, say, here's best practices for our migraine patients, which have a huge overburdening of ER visits. How can we select those patients out better to more aggressively manage those who need to be managed, and basically working together between the two groups to try to improve that care, but to really say, well, if the standard of care is this, how closely are we actually meeting that standard of care? And if we're not meeting it, what resources are needed to get there? So I think those are ways to really connect primary care with neurology. Another example would be if there is an individual, say, with neck pain, or they have radiculopathy, what are some steps that are needed before they even get sent to neurosurgery? That's a huge cost. And I think then just as an example, that we have, a huge number of spine surgeons, neurosurgeons that do spine work. And historically, there should be a 3-to-1 ratio of neurologists to neurosurgeons, for example. We are at a 1-to-1 ratio here in Alaska. And so the reality is that there's a lot more surgeons that are present. And the question is, are we doing surgery to all the people that really need surgery or not? And so really looking at which patients should be better prepared for surgery. Should we have a better pathway for those patients before they get to surgery, in order to reduce the negative outcomes that might occur, and sort of setting those programs and resources in place. Another example would be if I have a sleep patient that I'm seeing, and for them to do better, they need a weight loss program, they need other things, but they may not have a primary care doc. So aligning with a primary care physician that is well knowledgeable about what those needs are for that particular patient, and working together with them to get those better outcomes, I think would be really important. But we don't have those kind of conversations on a regular basis with our primary care providers. We don't know what needs they have, and they don't know what needs we have in order to meet those better needs, the better outcomes for our patients.
Thank you. There was a question that asks, are there other CIN initiatives in the state in addition to Providence? And the answer is yes. I'm aware of at least 2. Pinnacle is a CIN that has been in development for a number of years. And then there's one called Envoy that is being also developed at this moment. And some others may be aware of other CIN initiatives. So certainly there are others. Going down, there's a question, what metrics are PAMC using to select providers to be part of their CIN? And so this, of course, will vary based on specialist, but the nature of a CIN is it's focused on quality. And so as we think about different specialties, we look at data either from that we have internally from our own database, or potentially provided by the providers themselves around quality. And so it's hard to define a single metric, but certainly we are looking at data. And as we move forward, then one of the dimensions, and this is actually a requirement of the FTC that there be a quality program, and that the CIN actually has to have the ability to manage quality among the providers. And what that means, and this is a little uncomfortable, I think, for some people, but that a provider, excuse me, if their results are outliers and inconsistent with the norm in the community and the norm in the CIN, then there is a process of helping that provider improve, and if improvement doesn't come, then there may actually be then at times the provider may need to leave the CIN. And we actually, what I understand from our consultants is that doesn't happen very often. That generally, when providers see data and see their performance and see how they can improve that just the nature of why they're attracted to providers, they make changes. We've got about 5 minutes left. I'm just looking over. There's a question: are there legislative measures needed to increase use of value-based care models? There could be. At this point, there's only one that I'm aware of that may be helpful, which is to allow Medicare Advantage for state of Alaska retirees that are part of the state of Alaska retiree plan. And so that's something that will be in discussion with different stakeholders about. Medicare Advantage is a value-based program through Medicare, and it provides many of the benefits that we've discussed today. It actually has an enhanced reimbursement to the physicians, and allows the design of a program that compensates for preventative care and many of the attributes that we've discussed and that are critical in a value-based care model. And so it's something that we are working towards and anticipate bringing to the marketplace, and I think will enhance both access and care to to our Medicare population. There was a post there by Dr. Quinn about the Envoy CIN, and you can look at that. Then just seeing if I've missed anything. Sandra Heffern again asks, the Alaska Healthcare Transformation Project continues to work towards controlling the cost growth rate of healthcare in Alaska, increasing access to primary care, and addressing HDOH. Okay, that's not really a question. I'm just trying to see if I've missed anything. If anybody sees it, please.
Sheldon, when you have a moment, go over to the polls tab. It's interesting that there was a poll question being asked: is your organization shifting towards a value-based care model? And the individuals that were, 38% are saying yes, and some are saying that they're not sure. But the majority are saying yes, they want to consider this.
That's great. That's interesting. Thank you, Rhonda, for highlighting that. And then the other question, has the pandemic increased Alaska's capacity to utilize value-based care? It's a more even split among the different responses, and so interesting. Good. Well, all right. Listen, our time is about up. I think we've got 1 minute left, and so if anybody has a question they want to slip in, let us know. But if not, we appreciate you being here. We appreciate the questions, and I think all of us would be happy to be available, independent of this forum, to answer questions or address any concerns that people have.